This morning we had Ken Rogoff on, and he said this is a war. Would you agree with that?
Well, I think we're at battle with this pathogen, and we need to implement these mitigation steps to try to curtail transmission. But I think what you're starting to sense right now is people want to understand when these current lockdowns and restrictions will lift, and when normal life's going to return, and when we'll begin to defeat this. And I do think that there's an end to this. I think we need to start defining what that is right now, and defining the stages of what a return to better times looks like and how we're going to get there. And, I'll just sort of pause, but I'll say it's not just a question of ending these restrictions. It's certain things are going to change. There isn't sort of an on-off switch here that'll flip one day. So we'll unwind some of the measures, and we'll adopt others. We'll secure also in the process a better toolbox to deal with this threat, which we don't have right now, which we can have in the context of the current epidemic, so we don't get caught flat-footed again.
I got an email from one of the nurses in my town who works at a local hospital here, who was chastising some of the other moms who are letting their kids go out and play, and maybe joking around a little bit about this. She said that right now there are 42 cases in the hospital she works in. 6 of them are on ventilators. I think a lot of us know that something's coming. Maybe this is the quiet before the storm. What is this going to look like in a couple of weeks?
Well, I think we're going to see the healthcare system start to get really pressed and on the precipice of being overwhelmed. And we talk about assistance for the business sector. We ought to think about, massive assistance for the healthcare sector and the life science sector to try to build out some of these capacities. I'll give you sort of an example. We're focused on developing hospital beds right now. We're probably not doing enough. We also need to focus on developing places to discharge COVID patients to. So the two ways to increase hospital beds is, one, build more hospital beds, which we can do, but also build facilities or secure facilities that you can discharge patients to and increase flow. So what can you do? Well, you can increase reimbursement substantially for taking care of COVID patients in a skilled nursing facility or even home health that you might set up in a vacant hotel. If you increase that to 200% or 300% of Medicare, you'll see a market form for creating facilities or freeing up existing facilities that you can discharge patients to out of the hospital when they become stable. And that's going to, enable a lot of hospital bed capacity to open up. You're going to want dedicated facilities because you're not going to want to mix COVID patients with patients who don't have the virus. But we can start securing that right now. We need to start thinking about these things. With respect to all the shortages in personal protective equipment among doctors, we should be thinking about a national strategy to develop massive manufacturing capacity right now to crash manufacturing of some of these components. I mean, we built aircraft carriers in record time during World War II. Certainly, we can stand up a facility to start punching out some of these plastic parts that are missing for some of the diagnostic testing. We have 3D printing facilities and other capabilities. We're not focused on this in sort of a national way, in that we would need to if it was truly, to get to your first point, a wartime footing.
Can we just very briefly talk about what you mean by that? When we spoke yesterday off camera, you were telling me that the real problem we have with some of these testing kits is getting the access to the small ticket items, things like the swabs that you use to swab someone's nose. Why is it so hard to get those things?
It's always the lowest margin product in the supply chain that ends up being your weak link. You'll never have a shortage of the $100,000 scanner. You're going to have a shortage of the 1-cent swab or the little tip to the pipette that you use to get the sample into the cup to get it into the scanner. And those are the things that are going into shortage because they're manufactured in a small number of plants. The supply chain's limited. It's consolidated manufacturing precisely because it is low margin, and it's hard to increase the capacity of those plants on the fly. But if we sort of took a deliberate effort now to do it in a coordinated way, we could probably stand up manufacturing of some of these things in fairly efficient time frames. So we're short on the reagents, we're short on the swabs, we're short on the plastic pipette tips that go on the device used to move the sample into the scanner, and we're short on the little plastic cups that go in the wells on the scanners. And it's not that we're short, it's that we can only produce a certain amount each month, and we're using it up. We're consuming everything we make. And so the upper limit on what you can test in this country right now isn't defined by how many scanners we have. It's going to be defined by all these little low-margin commodity products that we should be able to commandeer some manufacturing in a market-based way, not take it over, but give people incentives to crash into these spaces and start developing these things.
Andrew?
Hey, doctor, I have two questions for you. They actually come from viewers who had sent me these questions over the past 24 hours. One is actually about Japan, and specifically why we haven't seen the outbreak and the pandemic there in really the way I think that most doctors and scientists had been anticipating, given its proximity to China and the travel between those countries. Do you have a view about what's happened there?
Well, they adopted mitigation containment strategies early, so they did do a good job of trying to contain the cases that they were finding. They haven't been screening a lot, and so it's a little bit of an anomaly where I've been of the belief that they have more spread than they're currently detecting. But it's been 2 or 3 weeks of me believing they have more spread than they're currently detecting, and you would think that you'd start to see a surge of cases show up in the healthcare setting. So it's not entirely clear whether or not they got lucky, whether or not the early containment strategies worked and they were able to separate people early and contain and quarantine people, or whether or not there is some sort of further spread in the society, and we're going to see those cases start to emerge. Remember, there was spread all through aggressive testing strategy where you identify people and quarantine them and contain the spread, or some combination of the two. We can get to some combination of the two. Right now, we're relying more on mitigation because we don't have the tools that you talked about in place. We can get those tools in place pretty quickly. I mean, this isn't something that we just have to wait to let this all pass and then we'll do this in September to prevent another epidemic. If we can get a point-of-care diagnostic onto the market, something that sits in the doctor's office, like the flu swab that you're accustomed to getting, or Cepheid's Gene Expert platform, you could dramatically increase scanning by just putting those tests in the doctor's offices. There's no reason we can't have that. The technology's there.
But do you see the American public sharing that information wherever they go publicly?
There's a way
like on a phone, having to get scanned to walk into a place. Also in Israel, supposedly, they're actually going to start tracking the phones to see if you've come in contact with other people with COVID.
Look, the technology is there to do all the things that you're describing. You need a logistics organization in charge of a national response to do this. You can't do it on a state-by-state basis and be very effective in a country where you have a very mobile population. So we need to do this at a national level. Big states can do it, but ideally you'd want one national uniform platform. We should be doing it. South Korea implemented all the things you're talking about, and they had, perhaps the best experience relative to the outbreak, the size of the outbreak they had. They were able to quell it quite efficiently using technology and a case containment strategy, coupled to mitigation steps where they did shut down, parts of the country on a rolling fashion in schools, but they did it in a very deliberate fashion.
Hey, Scott, to this point, the conventional wisdom has been that this is dangerous, but mostly only for people who are ages 50 and up, but especially for people even older than that. Yesterday, there was some new data that came out, though, that suggests this is quite a bit riskier for anybody who's age 20 and up. Can you talk about those numbers?
Well, that's right. And there's new data out of in Nature this morning, a model that looks at the fatality rate in Wuhan and estimates that it was lower than what was previously estimated. They estimated that was about the case fatality rate was about 1.4%. But what they show is also a linear increase in hospitalizations as age increases from 20. And that's consistent with what the CDC put out a couple of days ago on the experience of the first about 2,500 patients here in the United States, where they showed a very high hospitalization rate among those, 20 to 44, 45 to 54, 55 to 64, and also a high case fatality rate. And the case fatality rate for those 45 to 54 was 0.5 to 0.8. That's very high. With seasonal flu, we say the case fatality rate overall is 0.1, so it's significantly higher than that. But the other thing to remember is that the case fatality rate in flu is 0.1 because it's being driven by a high case fatality rate in those over the age of 65, where it approaches about 1%. But the case fatality rate for a 45-year-old with the flu is like 0.02 or 0.01. So this is, 10 times perhaps more deadly in a 45-year-old than the flu. It's just that you're dealing with a lower number overall, so it doesn't look as startling. But that's a very high increase in morbidity and mortality among a healthy 45-year-old. Than relative to flu. 54 to 64, the case fatality rate on the CDC data was 1.4 to 2.6 in a range, and the hospitalization rates are high. Overall, between the ages of 20 to 54, the overall hospitalization rate was about 40% of all hospitalizations were between that age. That's almost spot on with what China's experience was, where they found that 38% of all their hospitalizations were between the age of 20 to 55 in the province of Wuhan. So, young people are getting sick, they're getting hospitalized, they're not dying at the same rate as older individuals, but some of them are getting into trouble.